Welcome. Today we're focusing sharply on ulcerative colitis. Okay, great. Let's start right at the beginning. For anyone needing that quick refresher, how do we define ulcerative colitis?
Sure. It's a chronic inflammatory bowel disease. The key thing is its pattern: continuous inflammation, mucosal inflammation, and ulcers. And it's specifically in the colon and rectum. Continuous, not jumping around.
Right, continuous. That's an important distinction.
Right.
So scope-wise, how common is it? How many people in the U.S. are we talking about?
The numbers are quite significant. It's approximately 1 million individuals in the United States.
1 million. Wow. Okay. And when does it usually show up? Is there a typical age or certain groups at higher risk?
Most often, diagnosis happens before age 30. But really, the onset can occur at any age. As for risk, having a first-degree relative with UC increases risk. Also, individuals of Ashkenazi Jewish descent show a higher predisposition, and it affects men and women equally.
Good to know. Okay, let's talk clinical picture. What are the main symptoms you should be watching for, the sort of red flags?
Right. Well, classic symptoms include persistent diarrhea, often with blood hematochezia or pus. Abdominal pain is common, rectal bleeding too, and tenesmus, that urgent feeling to go, even if the bowel's empty. Also, look out for weight loss, fatigue, sometimes fever. And crucially in kids, impaired growth and development is a big one.
That's quite a list. What about severity? Is it usually severe or does it vary?
It varies. About half, maybe 50% of patients have mild to moderate disease activity. But it can definitely range. And some people experience very severe disease.
And understanding that range probably ties into classification, right? How do we classify it based on where the inflammation is located?
Exactly. We generally break it down into 3 types based on extent. There's ulcerative proctitis, that's just the rectum. Then left-sided colitis, which goes from the rectum up through the descending colon. And finally, pancolitis, where the entire colon is involved. Got it. Proctitis, left-sided, pancolitis. Helpful for thinking about management. Now, complications. This is critical. What are the major ones providers need to have on their radar?
Absolutely critical. Severe GI bleeding is a major concern. Also, colonic perforation. Those are emergencies. Dehydration can become severe quickly. Anemia is common. Long-term, think osteoporosis, and a significantly higher risk of colorectal cancer, which means surveillance is key. And don't forget, toxic megacolon, blood clots, thromboembolic events, and like we mentioned, delayed growth in pediatric patients. It's systemic.
A really broad impact. Okay, shifting gears slightly. What actually causes it? Do we know the etiology?
It's multifactorial. We know it involves a dysregulated immune response and a genetic predisposition.
Yeah.
But a specific single cause, like a particular bacteria or virus, no, that hasn't been identified.
Which leads to a common patient question, maybe even something colleagues wonder about. What about diet or stress? Do they cause UC?
Yeah, that comes up a lot. The short answer is no, neither diet nor stress causes ulcerative colitis. But, and this is important, they can definitely exacerbate symptoms, make flares worse, more intense.
Okay, so not positive, but triggers. Good clarification. So if you suspect UC based on symptoms, what's the definitive diagnostic method? How do you confirm it?
The gold standard is looking at the tissue. So histopathological examination of biopsies taken from the colon's lining during an endoscopy. That gives the definitive answer.
Endoscopy with biopsy. Got it. And once confirmed, what are the main treatment strategies? What's in the toolkit?
We have several approaches. Anti-inflammatory drugs like corticosteroids for flares are common. Then there are immunosuppressive medications for longer-term control, and increasingly, biologic therapies targeting specific inflammatory pathways. Of course, symptomatic treatments help manage day-to-day issues, and surgery is an option when medical therapy isn't enough or complications arise.
With those options available, is there actually a cure? Can UC be completely resolved?
Unfortunately, no. There isn't a cure for ulcerative colitis at this time. But, and this is a crucial message for patients, medical and surgical treatments can be very effective. They can induce remission, keep the disease controlled long-term, and really improve quality of life.
That's a key point. Managing it effectively is the goal. Well, what about lifestyle? What advice do you give patients on that front?
Lifestyle adjustments can certainly help manage symptoms. Things like maybe limiting dairy, eating smaller, more frequent meals can be useful. Staying well hydrated is important. Avoiding caffeine and alcohol might help some people. Also paying attention to personal dietary triggers and definitely incorporating stress management techniques. It's about supporting overall well-being.
Makes sense. And finally, when should someone experiencing symptoms seek evaluation? What signs mean get checked out now?
Persistent changes in bowel habits are key. Diarrhea that doesn't quit, especially if there's blood. Also, rectal bleeding.
diarrhea that just isn't responding to simple measures, or waking up at night with diarrhea, and any unexplained fever lasting more than a day or two warrants a prompt medical check.
Excellent. We've really covered the core facts on ulcerative colitis, actionable knowledge for you, the healthcare providers listening. Having these points clear helps navigate patient care.
Absolutely. And perhaps a final thought to consider. Knowing all this, how can we best fine-tune our patient communication? How do we make sure we're catching this early and intervening effectively?
A very relevant question. Thank you for joining us for this Focus Knowledge Update.